My point will be, or I try to speak about the importance on harm reduction. So I will go a little bit back and describe the importance of harm reduction, the philosophy of harm reduction, and the importance to involve service users, peers, and the community within everything we are doing on harm reduction, but also in the broader field of drug policy and hepatitis C, HIV prevention, and so on. So we get funding from a couple of companies for our activities in the area of hepatitis C. But shortly to explain, I'm a social worker and I'm German. I came over to the Netherlands in the 90s to work for services in Amsterdam for foreign drug users. In those years, it was a very attractive city to come over because of the differences in drug policies. But that was also the need to learn more about how drug policies function in other European cities and countries, and also probably to refer people back to back to family or back to their own environment. So that was the reason that we started with a lot of European work. Our organization here in Amsterdam is just 500 meters close to the station, and it's a service provision only working in Amsterdam. We have about 25 drop-ins. We have 4 drug consumption rooms, 1 for foreign drug users, the only one where injections take place. The other 3 consumption rooms are for Dutch users, which only inhale or smoke. So we have a lot of working reintegration programs. It's not only focusing on drug users, it's homeless people, people with mental health problems. So it is a diversity of services we provide here. And I'm one of the coordinators of Correlation Network, Indeed, which was funded in 2004 and has a relative broad mission statement and program, access to health and social services. But in first instance, it's about harm reduction. Things more or less is mostly funded by EC programs. We have through the years 180 partners in all European countries. We have focal group points in every country, and we work with hundreds of organizations all over Europe. And in recent years, I think since more than 10 years now, we focus a lot on hepatitis C, and we had a special program on that. So once again, we provide a lot of guidance documents, manuals, trainings, and so on, and we're organizing workshops and policy sessions in the European Parliament and so on. Just recently, we started a project, for example, on civil society involvement in drug policy, where we assess this situation in all European member states, and we will work in 6 pilot countries where we, with our local partners, try to establish meaningful structures for such a dialogue, just to give you an idea about the perspective of our work. So now I will again a little bit back and speak about harm reduction principles, because I mean there's a lot of talk, and Peter mentioned the effectiveness of harm reduction approaches, and I think yesterday, I wasn't here yesterday, but Olaf told about and we all know that drug users are one of the major groups of patients, and so it is there. But what I miss very often is that there is more. I think we need more integration. I think if we have a research, academic conference with a lot of medical staff involved, we should also integrate community and harm reduction workers in that, because there's a lot of knowledge out there, and I will speak a little bit about that. So what is harm reduction? Once again, and I'm sure you know that, but let's just to remind, harm reduction refers to policies, programs and practices that aim primarily to reduce the adverse health, social and economic consequence of drug use, of legal and illegal psychoactive drugs, without necessarily reducing drug consumption. And of course, that is the main point. That is that harm reduction accepts the use of drugs, and it is not in any way patronizing people, for example, to stop that. And as you know, that causes a lot of ideological discussions. Harm reduction benefits people who use drugs, their families, and the community. The harm reduction approach to drugs is based on a strong commitment to public health and human rights. So it is not only a technical tool to share share needles or to provide OST treatment. It is also to do with human rights, and that comes in areas again of political commitment, speaking about decriminalization and these kind of issues. But harm reduction is more than just a technical tool. Historically, almost all harm reduction programs, service models, and policies have resulted due to community activism, and that is also very important to know. Harm reduction itself has been developed, implemented, and operated by community members and resulting from the need to survive and to improve quality of life. The success of these programs has been critically dependent on peer and community involvement and will only continue such success with meaningful community involvement from the ground on. And to look into the history, how harm reduction was developed in the 80s, you clearly can see that it comes out of community movement. So in 84 in Amsterdam, the so-called Junkie Union began a program allowing drug injectors to exchange used syringes for clean ones to prevent HBV. So that was one of the first needle exchange programs out of communities. The same happened in 96 in UK in Liverpool, where the Merseyside project, former drug users promoting policy and service provision, developed integrated clinics for users. In Australia, the AFIL project provided NSP advocacy and support. In New York City, the ACT UP Now in New York underground NSP provided by activists, former and current users, which achieved to change laws in regard of needle exchange programs. Harm reduction services started in these cities provided the foundation of services development and opportunity for research that had led to harm reduction services we see today. So if understanding that, we should understand that involving the community in these processes is until now an extremely important thing. If we look on harm reduction situation right now, it is internationally recognized, starting with in the small projects in the cities I just mentioned, and in a couple of others, of course, as well. But it started with from very short projects, and now it's internationally recognized as best practice to prevent the transmission of bloodborne infections, promote safer drug use, increase access to social service and support, and prevent and resolve overdoses. In 91, following the last harm reduction international reports, 91 countries included harm reduction in their national policies. You can say only 91, but still I think it's a great success, of course. At the same time, what we see in recent years also in Europe is that harm reduction is under pressure. In some countries in Europe, even because of ideological reasons, I would mention Hungary here, for example, in many countries because of funding problems, economic crisis, and so on. And even if we know that it is a very cost-effective measure, a lot of harm reduction projects and services are reduced due to cut in funding. Just recall on harm reduction service. What is harm reduction in reality? Programs that distribute sterile needles and other harm reduction supplies, OST treatment, take-home naloxone programs, supervised consumption facilities is a relatively, it's not really a relatively new phenomenon, because the first room ever was established in Switzerland in 1880 already, and in Germany in 1992, in the Netherlands in 98, and then from 2000 on, even more countries implemented such rooms. Currently, we have 90 of such rooms, 88 in Europe, and 1 in Sydney and 1 in Vancouver. But there are a lot of countries on the waiting list or shortly hopefully can open such rooms. So Seattle is on the very top on the list. In Slovakia, they opened a room which is in an experimental phase. In Paris, they just opened a room, and in Strasbourg, so in France, and we have a couple of islands, I think, is just changing the law to make this happen. So there is some movement on that issue, and we just launched a study under the existing drug consumption rooms and their programs in regard to hepatitis C. So outreach and education is another main activity on harm reduction, and peer-delivered services, once again, is another important element. The evidence it works is mostly based on HIV research. So I think Don Jallet from US research in the 90s had the largest studies on that, and he documented indeed for the first time the fact that NSP is the most effective HIV prevention, and we saw a dramatic decrease of infection rates, and of course when NSP is implemented. And I only need to refer to the WHO document, which recommend all harm reduction measures as effective means to prevent infection. You know about that. That's not a point. But coming back to the drug user involvement and the importance of that, peers in the context of harm reduction are people which lived experience of drug use work both behind the scenes and at the forefront of needle distribution services, harm reduction education, peer support, and community-based research initiatives, providing valuable insights about the barriers and facilitators to accessing harm reduction services in their communities. So, but it's not only to use peers as educators, let's say to educate them, to train them, and then send them out. It is more an empowerment element which should be there. And in recent years, peers or drug users as such have improved their capacities, and they have a lot of self-organization measures. So this is really a relevant factor now, as well as in Europe, as well as worldwide. Most probably, you know the international network of people who use drugs. And we have also in Europe a lot of very reliable, highly competent drug user groups and organizations who work also in particular on hepatitis issues. One of the highlights I always like to mention is the Swedish Drug User Union, who have huge programs on hepatitis. They established hepatitis academies all over the country, and they work very closely together with medical sector and the treatment sector. So that is absolutely one of the best examples how effective and important that is. And there are a lot of more examples than what I mentioned here. So like in Antwerp, where you can see a very excellent model of how to integrate drug user groups and peers into existing extensive harm reduction services, or the Prola user group in Norway, which delivers harm reduction services to their own peers. And that's the way forward. If we look into, we are in the Netherlands, and Netherlands is one of the core countries of harm reduction, one of those, as you know, who implemented harm reduction for the first time. The AIDS epidemic, of course, was a driving factor to implement these measures, but it was not only AIDS, it was a broader view on on a drug policy than only to avoid infection. So initially, harm reduction was an offshot for the drug user movement. Notably, it was the Dutch activities who established the world's first needle exchange program, set up by here in Amsterdam, the MDAG Belangenvereniging Drug, in 1984. Sorry. So if we look into the service in the Netherlands in regard to harm reduction, Of course, needle and syringe programs have been established for more than 20 years in the Netherlands. These programs are mainly implemented by drug workers, addiction care providers, and the municipal health services who play an important role in the Netherlands to delivering these services. There are around 150 specialist agencies for needle and syringe programs. In some cities, also pharmacies provided. These are the recent EMCDD data from the last 2016 report. I'm in a way surprised that there are still so many supply for needles and syringes, because there is a dramatic increase since many years in terms of injecting drug users in the Netherlands in our consumption rooms. First of all, they do not inject, as I said before, and the average age of our visitors is above the 50. So there are no young people attending our rooms, because there are other drug-using patterns. Opiate use is totally out, and so it is getting older. Becoming older population together with us, and harm reduction also here has to reorientate and to see how to approach and how to get in contact with the younger population of drug users, because it's of course not so that young people in the Netherlands don't use drugs anymore. Regarding to MCDDA, for example, we have the highest rate of ecstasy use under young people. It's in the Netherlands. Well, very shortly again, yeah, as we know, prevalence among every injectors in Europe 30 to 80%, and in the Netherlands dramatically lower. In absolutely numbers, about 52 acute HCV infection cases we reported. 39 had a known transmission route. Injecting drug use was reported as a likely transmission route for 2 cases. The Amsterdam cohort recently data also indicates a decline in HCV incidence. So in general, available information suggests that the incidence of HIV, HBC and HCV has remained at low levels for many years in the Netherlands, which is attributed, obviously, to the widely available harm reduction services. So what we see as in other countries, that in the MSM community, injecting crystal methamphetamine, slamming, and increasingly recognized as a potential source of new infections. So it's still items we have to look at. What we are doing as correlation is, as I explained before, we have capacity building with trainings. We have a main issue on peer involvement. We have a huge information websites on methodology issues on how to involve peers and in services. And we built an online resource center providing current information on HCV research, treatment, prevention. This is targeting harm reduction workers, health workers who are not so much experienced in approach academic data centers and resource centers. So to link research knowledge to people working practically on the floor. In 2014, we issued a Berlin Manifesto, which were developed by, again, a lot of different groups with different backgrounds, and this manifesto also addressed decriminalization and people who use drugs, because we think that is connected to stigma, obviously, to discrimination, and and consequently also to access to testing and treatment. And what from my point of view was a great success was that it was also signed by the World Health Hepatitis Alliance, by ELPA, and the other networks who signed are quite obvious to sign, but so we achieved to bring that to a broader audience. Just to make you aware on a session we will organize on the 18th of April in Amsterdam. It's just one day before the EASL conference taking place here. We will organize a community summit on viral hepatitis. If you follow that on our website, we would be happy to see you here again. So the challenges, and I focus here on the challenges for harm reduction as such, that this is the first one is a policy challenge. Integrating harm reduction programs in the continuum of care will require policy changes to allow HCV testing on site. In many countries, this is not still not possible, unfortunately. Funding, of course, is a big issue, but so funding to increase coverage and capacity within harm reduction programs to hire dedicated staff to do HCV work. So also in many harm reduction programs, there's not enough capacity in terms of skills and in terms of funding to do HCV work, which should be one of the priorities. Ability to provide needed amounts of injecting equipment, increased skills to provide behavioral counseling to prevent new infection and reinfections under drug users, to be able to tailor service to create user-friendly spaces for MS and prevention as prevention. So if we speak about treatment as prevention, we may not forget also to address prevention as prevention and to equip that with sufficient funding. So as a conclusion for me is an important element to eliminate HCV in people who use drugs is a full acknowledgement of harm reduction approaches. Consequently, harm reduction has to be a fully integrated part of hepatitis C strategies, action plans and implementation finally. Thank you.